coming into the 1990s, several backdrops. One is that the recession, when it came in Canada, was a little deeper than it was, for example, in the United Kingdom. So we actually saw in the early 90s a 6% drop in GDP over a three-year window, and the consequence that that would have for the healthcare sector. But there was a kind of a double whammy in Canada, because as a federation, we came in and the federal debt, through a kind of heavy spending in the 80s, provincial spending was high too, but the federal debt was approaching 70% of GDP, a little north of where you are right now within the UK. And so there was a dramatic pressure to get to balance for the federal government and also for the provincial governments. So there was a burning platform. There was a burning platform. There was concern from the bond rating agencies about lending the country money. There was concern at the provincial level, and I mentioned this point that the federal government actually had to underwrite Saskatchewan's bonds in the early 90s because the agencies wouldn't lend Saskatchewan money in the absence of federal guarantees. So what happened in the early 90s is that the federal government took in earnest an objective to get to balance within the decade. And in the course of doing that, they pulled back from major transfers to the provinces. So the provinces actually faced two fiscal shocks in the sequence of the 90s. One from the general downturn that occurred in the early 90s, and the second in a pullback in federal transfers, which really occurred in the mid-90s, where several $1 billion were pulled back from transfers. So there truly was a clear and present danger for the provinces, and I think a burning platform to take out some capacity at the provincial level.
Can you give me a sense of the sort of scale of the change that this meant in terms of jobs and in terms of salaries for staff, in terms of actual hospitals being closed?
So very significant scale across the country. Effectively, beds were being closed. Some hospitals were being closed, Saskatchewan being the most dramatic, with these small rural hospitals being converted. Nurses were laid off. Large numbers of nurses were laid off in the course of the reforms throughout the 90s. Physician wages were capped off in sequential steps to try to reduce the growth of human resource costs within the sector overall. So there was a very significant change in the composition of the workforce. A number of the provinces introduced adjustment policies to deal with the problems which would be faced by the nursing layoffs. And of course, the effects on the workforce were not insignificant, and there was quite a lot of, I would say, unhappiness which could be tracked through public opinion polling throughout the 90s with in the general public about the contraction that was going on.
The real fear here would be that by cutting particularly nursing numbers, you'd be compromising the safety and quality of care in hospitals. Looking back, did you see any signs of harm in that sense?
Well, maybe a bit of a complicated answer. I think in the first instance, there was quite a lot of public concern about harm and whether there would be a compromise on cleanliness and patient safety and so on in the sector overall. I would say the net effect in looking back was to actually raise hospital productivity during that period of time. So doing the same kind of work with a different configuration in the workforce, a smaller workforce effectively, and substituting a lot of inpatient care for outpatient care. So throughout that window of time, the numbers of patients served continued to grow with secular growth in the population and aging. And so hospitals became more productive during this window of time. I would say the big harm, to the extent there was a harm, was the growth in waiting times. And we wound up facing, in a number of areas, significant access problems towards the end of the 90s. And in fact, into this past decade, we had a Supreme Court judgment effectively calling provincial governments to arms to say, people are waiting too long, you are essentially breaking the fundamental undertakings of Medicare, and you're going to have to allow more private insurance if you cannot guarantee people reasonable access to care when the care is required.
You mentioned that public support had sort of fallen away. Was there any long-term, do you think, impact from this in terms of people's willingness to support and want a public health service?
I would say perhaps a little bit to the contrary. There was a sense that the health service may have been harmed. Although, I would say as an objective reality, the health service was actually made slightly more efficient, but with this problem of constrained access. And I think the general view in the public and in the stakeholder community and the sector of organized medicine, nursing, and the hospital sector was that a reinvestment was required. And in fact, following two major commissions of inquiry in the early 2000s, a very large reinvestment occurred, sort of bringing back the federal government's kind of, in a way, legitimacy by reinvesting very significantly throughout the decade from 2004 to 14. We have been working with an index transfer that has essentially restored where we were prior to the pullback of federal transfers. So I think the public was unhappy with the constraint and the contraction. The sector was made more efficient, and there was a reinvestment which followed. In fact, coming out of the recession, the trajectory of growth in the sector was actually higher than prior to the recession.
Now, we've heard about the experiences of two provinces. How did other provinces in Canada respond to this challenge? And do you have any lessons for the NHS in their experience?
Well, like my colleagues, I don't know how easy or transferable any of these lessons really are for the NHS. There's much in common. It's tax-based financing and the issues of constraint and how to deal with these. I think in some respects, each of the provinces in Canada they had master plans. Most of them had master plans that had been built in the early 90s. At least selective action on each of those master plans took place as a consequence of this burning imperative that each of the provinces faced. So Louise described a politically led and highly engaged process with the public, led by a minister, and with the full support of the cabinet and the government of Saskatchewan. Ontario took this very unique approach of delegating a special purpose body, a temporary special purpose body, delegated authority to consolidate, reduce capacity if required, but rationalize care and make the hospital sector more efficient overall. Maybe I'll use the example of Alberta. In Alberta, they built on a Premier's Commission report which suggested there needed to be an integration of hospitals into regional aggregation. And I would say, parenthetically, that the emergence of regional health structures in Canada occurred pretty much across all provinces in the last 15 years. But during that time, they surfaced very rapidly as a way of getting a kind of a horizontal integration capacity and being able to trade off more effectively between institutions. So in Alberta, they also had, at that time, more of a boom-bust economy, and they really had to take out some significant capacity quickly. They regionalized, and they did a very clever thing, which was to essentially create super boards from the existing institutional boards, and they abolished the existing institutional boards. So it was a form of accommodation politics within the sector, and then they passed on reductions. In a way, they delegated the difficult task of taking the numbers down to these regional boards, and they actually took the numbers down quite significantly in Alberta through the mid-90s through these regional boards. So in each of the provinces, an effective mechanism was identified to get the capacity reduced, to try to build a more efficient delivery sector, and to act on some of the reform ideas which had surfaced in the early 90s.